Hello, 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 everybody. My name is Joanna Dolan, and I am here with some of my friends, and we are doing Recovery Capital Podcast. So before any of us introduce ourselves, Recovery Capital Podcast is the place for the recovery care team to learn about recovery capital, to see how people are bringing out recovery capital in with all the people that they're interacting with in recovery, and also those who are seeking recovery. So whether you are a recovery care team member or you are in recovery yourself, we hope that this is fun and an opportunity to learn. And because this is our very first time ever doing the Recovery Capital Podcast, I can tell you that we are going to have some fun while we learn how to do this intro. And also, Recovery Capital, in case you don't know, is the internal and external resources that we all need in order to be able to live lives in recovery and no longer suffer from the ravages of addiction. So, Amy, you want to go ahead and introduce yourself?
That was good. You did good.
Yay!
I'm proud of you. Cool. Yes, my name is Amy DePietro. I sell potatoes by day. That's all I'll say about that. But that legit job. And then at night, I work for Colmac Outpatient Recovery Centers, and I do their patient advocacy along with their alumni program. I am the quote unquote in charge of that, although it's kind of a life of its own, if you will. So that's kind of where I'm at in this foray at the moment. And I too am in recovery. I've been in recovery since November 28th, 2012. Not my first time in recovery, but hopefully my last go rounds. We'll see how it goes.
I like it.
Yeah, I think.
Excellent introduction, dude. Bob, you want to go ahead and introduce yourself?
I'd love to. Thank you so much for asking me to be here. It's a real honor to be part of y'all's first podcast, and I'm really looking forward to chatting with you. My name is Bobby Coffey, and I'm a person in long-term recovery also. And what that means for me is that I haven't had a drink of alcohol or mood-altering drugs since February 21st of 1991. And because of that, I'm a better father to my children and now grandchildren, better, sibling, a better, co-worker to my colleagues, and a productive member of my community. And because of the gift of sobriety and my recovery, I'm here with you guys, and I get to talk about things that are of interest to me, and I'm really, really happy to be here, and I'm looking forward to our conversation.
I just also say that for a man who has grandchildren, you still also have a killer head of hair.
About that.
Yeah, I mean, look at that.
Thank you, Judge Raymond. Yeah, the grandfather.
I love it. It's so good. It's serious.
They may have given me the alcoholism gene, but I got the good hair gene from him. I
guess. Absolutely. I love that.
That was such an awesome segue.
Well, I don't know that, because obviously I've met Bobby before. We've been online together before, different things and whatever, but I don't know that I ever noticed his hair. It's got like pretty quality do.
Thank you for that.
He does.
I don't want to make him blush though. So
moving on.
Yeah, segue back.
Moving on.
Yeah, moving on.
So the reason that we introduced that, well, first off, oh my God, thank you so much for coming on our first show, Bobby. Like, that is massive. Like, you say that you are honored to be on our show, and we are honored to have you. Like, I mean, that you just said yes.
Right?
I didn't even have to think about it.
So, oh my God, yeah. So let me tell you why we are so excited that you said yes. So Bobby, for those of you guys that don't know Bobby Coffey's name, Bobby was on the board of Faces and Voices, and he had a lot to do with the whole language research, anti-stigma project, and the language that you heard him introduce himself with, right? And so that's why we brought him on, is because we want to have a conversation about that. What do you
Yeah,
think?
you know, it was really interesting that my first year on the board at Faces, you know, they actually went out and asked a public relations firm what when you say long-term recovery, they asked a focus group, what does that mean when you say I'm in long-term recovery? And what they found from the focus groups were that people in focus groups said, well, that's probably one of those people that goes to those meetings and they probably hadn't had a drink, you know, in a few months or maybe a year, you know, and, you know, really 5 years is a long time, but they didn't really think that 30 years of sobriety or 10 years of sobriety was something that was achievable. And so they came up with this language and then they went around the country teaching the language to people in recovery. And one of the things we also learned was that a lot of people like me, and I think at the time I may have had 12, 15 years of recovery. So it's been a while ago. What we were finding was there were a lot of people that were in the rooms that were reluctant to be advocates because they didn't want to violate any of the traditions. And whenever we would talk about it, they would say, yeah, but that's, you know, when I'd ask somebody to go testify before the city council or do something, they would say, no, that's against the tradition. So by coming up with this sort of language, it gave people a way to be advocates, you know, because if we're not advocating for ourselves, then we've got other people that don't understand the disease of addiction setting policy for us. And that's just not a good place to be in.
Nah. Oh my God, you were so right on about that. So like I'm literally sitting here thinking in 97, that's when I entered recovery, and I've stayed thankfully since then. And 10 years ago, if you had said to me, you know, like, would you come testify? If would you come testify? Would you have a conversation like this open? I'd have been like, nope, violation of traditions.
Right. And I'll tell you the other thing that was really meaningful for me is, and I'm trying to think of the year that it was during Recovery Month, and a friend of mine asked me if I wanted to go down to the Capitol and listen to Congressman Jim Ramstad from Minnesota, and Congressman Patrick Kennedy talk during the special orders section, you know, at the end of the day about, and I heard them both talk really personally about their alcoholism and mental illness. And I was going, wow, you know, this is a guy that's talking in the well of the United States House of Representatives about something so personal. And basically, you know, coming away from that, it sort of gave me permission to, like, I can talk about this, you know, I can, you know, and they talked about reducing stigma, and that was really the launching point for me to speaking publicly about my alcoholism, and you know, I testified before the DC City Council on the repeal of laws that were barriers to treatment. I testified before the FDA about, you know, the extending the use of Vivitrol and medication-assisted treatment. I testified both the House of Health and Human Services about extending, you know, recovery support services in the Affordable Care Act, you know, and I did it using this language that I introduced myself. That's the way I did it, and it's just, and there are a lot of other people that I know that think like you and I think, you know, that are now really good advocates, you know, because, you know, we changed our thinking on that, you know, on whether or not it's a violation of a tradition or something like that. So it's cool.
It's super interesting that you guys are talking about that, because so I didn't get sober till 2012. So for me coming in, it felt different than your experience. I guess there had been a lot of groundwork that you have done to kind of change the culture a bit. So I was encouraged to be transparent. I was never like told, go ahead and like break your anonymity, right? Like that was a personal choice. But it felt, and maybe that's part environment, like, you know, being so close to Washington, D.C., being in a pretty highly, you know, like a melting pot of individuals, all kinds of like socioeconomic backgrounds around. I don't know, I didn't feel as much stigma at the time. I feel like there was a lot of conversation happening about mental illness, and that it was okay to be engaged in therapy, and it was okay to ask for help, and it was okay to go out and try to source, you know, assistance for yourself. And so I feel very fortunate that I didn't experience a ton of negative self-talk, right? Like, it wasn't coming at me. As a matter of fact, the opposite was being encouraged. So,
well, that's really good to hear, you know.
yeah.
That's really good to hear. And it's sort of interesting, you know, back in the, I'm not even sure what year it was, Amy, but you know, back when Harold Hughes, Senator Hughes was there, and there was
the 50s.
Yeah, in the 50s, where they convened like Dick Van Dyke and all these Hollywood types to come testify before Congress. You know, that stigma was, they were making headways on reducing stigma, and then all of a sudden along comes, you know, the war on drugs, and then we're incarcerating people, you know, that suffer from the disease of substance use disorder, and people sort of went back, you know, pulled in their little heads into the shells and didn't talk about it as much. And now, thankfully, you know, it's coming back a little bit, and, you know, for good or bad, you know, there are a lot of people that talk about their recovery, and it's all good. But there are a lot of people that talk about it, maybe that shouldn't talk about it, but that don't have, you know, recovery, and that have it then lose it, and have it and lose it. But I think from the most part, it's really good for people to be vocal about that recovery works, you know, and letting people know, because a lot of people just don't think that it works, and we're examples that it does. You know. What
do you think was it that the way you just kind of outlined, right? Like from the 50s, you know, kind of people speaking out against it, and then war on drugs, which I'm really kind of, we're talking about the Reagan years, right? Like all kind of got kicked off.
The 80s.
But you're right, like everybody kind of withdrew a little bit, right? And we declared war on everybody that was bringing anything into this country. But so when did that shift kind of come back around? Like, what was the catalyst for that, do you think?
Well, I think it was is probably in 2000, in the early, you know, the 2005, 2008, that area, when we started talking about mental health parity. We started talking about you know, the Affordable Care Act, those type things, when we made the disease of addiction, you know, the requirement, the parity law, that where we had you treat it just like any other illness. I think that was when a lot of people started coming out about it. I think it was like, you know, when I was on the board of FACES, and we started talking about this language, and I think that made some headway. And then I think it really took off when in like 2017, and when Michael Botticelli was the director of ONDCP, the Office of Drug Control Policy, and he came out with his paper on the use of language, and it got a lot of traction, and we can talk about that. But I think that is also, you know, provided a lot of fuel to this movement of people talking, you know, openly about the disease of addiction.
Don't you think too, and I don't know, this is my it would seem as social media has evolved, so has conversations about it. That's how it feels to me. I don't know if you guys agree or what, but you know, it's like nowadays anybody can take to a podium and, you know, kind of give their 2 cents and talk about their own experience. And it would seem that that is a fairly empowering journey for people to take. You know what I mean? Like that's kind of big stuff. And I mean, so much so that I think about the traditions like we've talked about in like Alcoholics Anonymous or any 12-step really.
Mhm.
As a result of social media, like even 12-step has had to like kind of evolve a bit in how to accept that this is happening, but still protect anonymity in some regards. I don't know, it's been in the 8 years is when I think about it, not a huge chunk of time.
It's still a long time.
Well, compared to you two guys, you know what I mean? Like,
I mean, it's still a long time.
You got sober in 97. I was still smoking weed and barely graduated high school. You know what I mean? Like we were in different places.
You know, Amy, you're right about that because, you know, I'm, you know, active on social media and I look at things, and there are people that like on Instagram that are running reels about their recovery and I love it, you know.
I do too.
I think it's great that people are sharing their recovery in that way, and I think it should be supported. And you know, you meet people where they are, right? And and there are a heck of a lot of people there. So I'm really happy to support that sort of initiative.
I think it's so cool. I love it.
It is cool. So let me ask you, so before we go much further, when we talk about language, let's get clear about that, right? So like there's times I call myself an alcoholic and a drug addict. I'm not, I don't suffer from those things anymore, but like I've seen like a lot of social media posts saying like, don't call yourself that, you know, don't use that language, which, you know, that's kind of hard to phase out of. Can you talk about that a little bit?
Yeah, you know, Joanna, I when you asked me to do this, I started thinking about it a little bit. I think for me there are 2 reasons why people don't seek recovery, and both of them are stigma, right? There's a personal stigma, and there's a social stigma. That personally is, I don't want to call myself an alcoholic. I don't want to say my name's Bobby and I'm an alcoholic. I resisted that with all my being. And then I don't want society saying, hey, there's Bobby Coffey, he's an alcoholic. I didn't want that. And those are the 2 reasons that I think people don't seek recovery. And I said, to the extent that we can reduce that stigma, I think it helps people. And the way that I think we do that is by not using language that perpetuates the stigma, you know, and it's going to take a while. But I think when, you know, like the AMA has come out and endorsed, you know, the use of patient-centered language, the ASAM has endorsed it, you know, in using patient-centered language in their clinical writings, you know, so I think that's a reason enough for me to want to do it. And then also, you know, in our work at Faces and Voices, you know, there was this whole initiative, Recovery Voices Count, encouraging people in recovery to go out and speak and get people that are candidates that are running on the record, you know, how do you feel about recovery support services and all of these things. And and the thing I've noticed in the last couple of cycles is that politicians now are, a lot of them, you can tell the ones that understand the issue and the ones that don't, because there's still a lot of them that don't use that language. And it's incumbent upon people like us to in a general way, kind of way, it says, you know what, we don't use that kind of language anymore. And if you want to be understood by people, people in recovery are a constituency of consequence now. And and we have to be able to go to policymakers and to candidates and say, this is the kind of language that you need to use if you want to be able to be understood by our community. And so I think in everything that we do, whether it's in our social media or whether it's in our everyday conversations, or maybe even working with our colleagues. I work in a clinical setting, and I hear a lot of times people using language like like a dirty urine.
Oof.
Yeah.
And we can, in a gentle sort of a way, say, you know what, we don't talk about, if you want to use patient-centered language, we
So
talk
tell
about
us what patient-centered language is first.
I was just going to ask that.
That its core really is the understanding that we put that the person that we're working with is included in the decisions, that they know the disease that they're dealing with. They should be part of treatment planning, and that we don't use language that stigmatizes the issue that they're facing. And but I think like I said, at its core, it's the understanding that the patient understands and should have a voice in their care. We should be asking them, what do you think about this? What do what are your thoughts, rather than dictating. I thought you did a really good piece on this, Joanna, in your recovery coach training. And I was trying to think about it before we started, what the language was about, about when we're talking with people, whether or not we're being, what was the word we used, an advocate, or
Whether or not we are treating people as objects.
Oh, yeah.
Or we're treating people as resources.
Resource, exactly. So,
Yeah.
I have a little bit of knowledge about, my history, and I don't want to be treated as an object. I can remember, and this is an aside, I can remember when I was going through, being treated. I can remember being treated by an on-call psychiatrist one time that was talking to me from behind a piece of plexiglass, and it's like they were scared of me or something. And
Yeah.
that's just kind of the worst, and we don't want that. When I ran a clinic and I taught, when I worked with clinicians and we talked about, how we're going to work with patients, I never wanted a computer between the client and the clinician. I wanted them to have a conversation, and certainly not talking to a client and as an object, but as using them as a resource. So there's lots been written about it. I mentioned earlier about the Botticelli article when he was at ONDCP, and he had some really great great suggestions in there. And that whole article had to do with the government and their writing and grants that they put out, and writings white papers that they put out, that they not to use stigmatizing language. And I just thought it was great. That was a huge step.
I just think about the difference in what you just said in terms of referring to someone as a client and not as a patient.
Right.
I mean,
this is a journey, right?
Yeah. I mean, you didn't even point that out. Like you transitioned through. Honestly, that's something that I had not even really considered. Like, because I like you have sat in across a desk from a healthcare professional. I mean, the first time I tried to get sober, 1995 or 4, and
I was still in high school.
and I was still in high school, so you know what I mean. And like I was an adolescent, so
yeah,
the whole time this person was talking to me, I never once made eye contact with me. They were looking at my mom.
Right.
It was it was if I was not in the room.
Right.
So there was no connection right off the bat. But I want to ask you a question, both of you really, as it pertains to the language. And I love what you're saying. I think it's so cool that we are even moving in a direction like this. How does that, how do I want to say this? Remember the first time you like could take a breath after saying, my name is Amy and I'm an addict?
I remember that.
So
me too.
I
Yeah.
mean, it gives me chills when I say it, and I think back on it, because in that moment I was accepting my situation,
Mm-hmm.
right? And so I don't want this to come out like the wrong way, but there's a part of me that is proud to say that I'm an alcoholic and I'm an addict, and I'm in recovery. Is on some level, because I'm learning and have been learning over the last couple of years how powerful language is. Is that damaging? Feel that way?
To use
Own it?
No, I don't think so at all. I don't think so at all. You know, you said something I want to touch on that, about our stories. Our stories have power. I mean, our stories have a lot of power, and when we share with other people, it's, we're uniquely qualified to work with people that suffer from this disease, because we've been through it. But we're much more able to make a headway than maybe say a physician, that hasn't, but I don't think that I mean, there's no right or wrong, but I still refer to myself in meetings. I still refer to myself as an alcoholic. There are a lot of people even in the rooms now that that refer to themselves as people in recovery that adopt that language. I still use it because I still use that language. But I remember when I was in treatment, I didn't refer to myself. The first time I ever said, my name's Bobby and I'm an alcoholic, was not in treatment. It was in a 12-step meeting.
Right.
In treatment, I would say, my name's Bobby, and I think I said I had an unhealthy relationship with alcohol. So that's awesome. And I got grouped for that pretty good. But I said it, I did say it on my own, unprompted, in a meeting one day, and it was powerful,
Yeah, it was.
to acknowledge that, because it is, I suffer from the disease of alcoholism, but I am in recovery. And I think that's the point that we need to make with people is that we do recover.
We do recover. Yeah.
And this is what it looks like when we do recover. It's like our families don't have to worry about us anymore. We don't, we're not involved in the legal system. We're productive members of our community. Our children get us back. My grandchildren never have to see their grandfather drink. Those are the things that we want to stress. We don't want to stress the things like, the cars that I wrecked or the lives that I hurt. We want to focus on the recovery. And that's the point I think we should be making.
Absolutely. So let me ask you a question. This is probably a little off topic, but I was introduced to person-centered language from the movie Anonymous People.
Right.
Did you have anything to do with like any of that?
Yeah, I knew Greg, and I know Greg, and I was interviewed for that, and I think I ended up on the cutting room floor. But the piece that they used, we previewed that premiered it, I guess. That movie, Aquila sponsored it at the Avalon Theater here in DC, and again, that was another big step in people coming out and reducing stigma. That was made a huge point. But I really I know a lot of those people that were in that movie, and I've done a lot of work with the Facing Addiction and the people that Greg knows. And then there's a whole website made out of the pieces that they didn't use in that, called Many Faces, One Voice.
Okay.
.org. I think you can look at. I think it's still up there.
What was it called, Bobby?
I think it's Many Faces, One Voice. Was a lot of the interviews were there. I think, and you can still. I think I've still seen a little video clip of mine up there someplace. But I think that documentary, and then the gathering that we had on the mall, in the driving rain, that incredible.
That was incredible.
Yeah, I wish that the weather had been better, but I think we had 30,000 people show up in driving rain to hear musicians come out and celebrate recovery, and such a powerful day.
Yeah.
A lot of really good stuff has come out of that movement, and it was fun to be there and to know that group, and to see their work evolve,
Mm-hmm. Yeah, absolutely. So one of the things that you said in there, I know I'm like jumping a little bit, but
Good.
one of the things you said in there was when you had Aquila do the premiere at the Avalon. So tell us about your work at Aquila, because you've gone from working with insured people to working with non-insured people, and we're very different along those spectrums, right?
The disease is the same, but the needs of those different communities are completely different. But I moved to Washington in right after 9/11, right? And and I worked in the.
Where did you come from?
I moved from Mississippi. So I think I was 11 years sober when I moved up here, and I immediately got involved in advocacy. And was part of the group that founded the DC Recovery Community Alliance, which was the first recovery community organization here in Washington, DC. And they're still operating now and work primarily with returning citizens. Great organization. And then I did a stint on the board at Faces and Voices. And out of that, I had an opportunity with some other people in long-term recovery to develop an intensive outpatient program that the core of that was to tie addiction treatment to the primary care community. We wanted more people to be referred to addiction treatment from their primary care physician and not the legal community, right? And
That's brilliant.
That was a brainchild of Johnny Allen, and who's done incredible work in this field for 40 years or more than that, probably. But that was the purpose of Aquila, was to, and we could have certainly opened a program in a more business-friendly environment, but there's a lot of power we felt in developing a clinic like that here in the nation's capital. And at Aquila, we started Aquila in February, I think, of 2011. And we work primarily with the insured population, because the interesting thing about the District of Columbia is at the time that we opened Aquila, there were 35 licenses to do addiction treatment in the district, and 33 of them were programs that treated people that were insured by block grant money, Medicaid, Medicare, by the public dollar of some sort. And so if you didn't have insurance, there were lots of places to get care, right? But if you had insurance, there weren't very many. What did we have? We had Colmac, and we had the EADP, and then we had Aquila. And as we know, that this is a disease that's progressive. And if you don't have access to care, and we wanted people to use their insurance. They were paying for it, or either their employers were providing it for them. And if they didn't get the care they needed, or if there wasn't a program to provide that care, what happens? The person loses their job, they lose their family, and they lose their insurance, and then they end up relying on the social safety net, right? So the people in the district love the idea that we were there, because that's one less person that would ultimately fall into their system and have to rely on the social safety net. So Aquila, the patients that we dealt with at Aquila, most of them were, almost all of them were insured patients. Almost all of them had good jobs, good families. Now, due to COVID, and I'm not part of Aquila any longer, I'm working with patients that the uninsured population, the Medicaid population, and patients that are in that system, and it's much more challenging. It's a much more vulnerable community than I'm used to working in, and but the good part about it is that there's so much that can be done. It's a good laboratory for trying new things, and Recovery Capital is a perfect one, to be working in that community. And we've actually developed the Recovery Capital Network at DC at dc.recoverycapital.org, and to implement a lot of the things that you've been doing, and it's just a really interesting. It's just a really interesting feel.
What are the biggest, or if there's like top 5 kind of thing, situation where, like the biggest challenges you face with helping the uninsured population from the insured? Like, for the layperson, like somebody that doesn't have any clue as to what goes into it, like the most basic type stuff.
Right. Just to go back, that URL I just mentioned is recoverydc.org. Amy, I think that the biggest challenge in working in this community is assisting the clients that we work with, and then in the vernacular in that organization is patients. They call them patients because I've been working in a hospital. Is connecting them, is the whole care coordination issue, and connecting them with getting patients to go to the next step in the process after they've been stabilized. What we're finding is that so many, maybe 25% of patients that come into the detox at the Psychiatric Institute of Washington are going to the next step, which is intensive outpatient or residential treatment, and that's a big challenge. Is how do you get them to go to the next step? And then there's so many people that are coming through the door. I think at PIW they're doing between 300 and 400 admissions and discharges a month. So
wow, that's a lot more than I thought.
Yeah, you're seeing a lot of people come through the system, and then a lot of them have gone through all of the different, residential programs in the city, and they may have completed it, they may have left AMA, So when you say, hey, I want to send this patient to this program, the program says, no, he left AMA, so we're not going to work with him right now. So they go to the next one. And a lot of what I'm seeing is a lot of these patients have cycled through all of them, and there's no place for them to go. So we're working really hard on integrating peers into this whole process, so that we can. And then the other thing is that there's some laws that now allow us to send certain patients to out-of-state treatment programs, and in order to do that, a lot of times you got to put them on a plane, and there are lots of different barriers to do that. Does a client have a valid ID, to get on a plane? I worked with a guy yesterday that was motivated and he was able, he had the right, insurance, and the clinicals worked out, but he didn't have a government issue ID, so he couldn't get on a plane to go. And it's really frustrating. I worked with a female patient a couple of weeks ago that she was able to go. She had an ID. But a lot of these patients come in with nothing, literally. She didn't have a suitcase. She didn't have, change of clothes. So they need clothes. They need I'm just talking with one of my colleagues today about getting funding to develop go bags, right? And have male go bags and female go bags, and having underwear, toiletries, and just a basic overnight bag to be able to, help them, get to care, and getting transportation to the airport, getting money for food. It's just, there's a lot of hand holding, and we're really hopeful that the peer support, we got funding for 6 peer support specialists to work with us in our central assessment, center, and then also on the discharge end. But there's a lot more challenges to working in this community than the one that I sort of cut my teeth on.
Yeah.
So I have a couple questions. Everything that we've talked about, like the articles and those types of things, we're going to link to it in the podcast notes, and also in the YouTube video notes.
Mm-hmm.
Are you guys open? So the first question is, are you guys open to people sending like donations for the go bags or that sort of stuff? And where would they send them to?
Right.
So we have, so if you go to recoverydc.org, there's a place to donate there. So people can, we have a 501c3 that people can make contributions to that. So that would be great. We would love that. There's so much, and it's not even that it's a significant amount of money, but every time that we send a patient to a program out of state, there's probably $50 involved, whether it's parking at the airport to drop them off, or whether it's food, money for food, for a layover, or, getting them a bag, or, buying them toiletries, or buying them underwear, or something like that. But it's like, so and if you look at the certain grants that we've gone for recently, there's not money in there for that sort of thing. So we're gonna raise that money privately, but we would certainly welcome and appreciate any donations at recoverydc.org.
Okay. Thank you for that.
Just
So
click
actually,
the donate tab. Yeah.
okay, that actually gave me 2 more questions, right? So one of the questions is like, okay, so I know that PIW focuses on Ward 5 and Ward 8 in DC. DC has been hugely impacted by the capital city riots. Is that what we're calling them now?
Yeah, I mean, are you talking about the
Capitol House riot?
Yeah, the idiots that stormed the Capitol.
I don't think we're allowed to say that.
Are we not?
I don't know. I mean, like, that's.
So I'm not sure what the question is.
So my question is like, has yeah, we went off on a tangent there. So the question is, how have you guys seen more people with need seeking recovery at PIW since the riots?
I don't. Joanna, that's it's always like a fire hydrant going on. So I'm not sure you can attribute it to more because of this or that. I think that I interface a lot with peer support people in the EDs around the district, and I think last week we did see like there was a big rush of people that that show up in the emergency departments around, and they're looking for care, you know, and you gotta treat them, you know, and so I really haven't noticed that why they're coming in. I know that, you know, when the weather is really bad, that, you know, we do get a lot of people that are experiencing homelessness that come in because they know that they can they can be brought in, and they know how to get admitted, you know, and and
contingency management.
yes. And you know, we when we bring people and we admit people, we can look, you know, in the system and see, you know, how many times this person's been there. They know the system, you know, and that's fine. And we want people to get the care, because you never know, you know, when somebody is going to get it. And the thing that I've just tried to do in the people that I interact with is really to treat them as a person and not as somebody that, you know, is, you know, known to the team, you know, and people just want to be treated with dignity, you know, and with respect. And
Well, they're human beings.
yeah, and you have to, and I think we have to model that, you know, we have to model that for some people. And and honestly, I'll tell you that I think I was having a conversation with a physician colleague of mine this morning, and we were talking about that topic, and unfortunately, there are a lot of places to get care, you know, to get treatment in Washington, D.C., but the pay scale for people providing that treatment in the Washington, D.C. is really, really low. And there's a direct correlation between, you know, compensation for providers and patient outcomes, you know, client outcomes. And until we can, you know, get the compensation for workers in our field up, I don't think that, you know, I think it's going to be really hard. So I'm certainly going to begin pushing that and making sure that people are compensated fairly for this work, because it's really, really important.
Absolutely. Well, and so I kind of see it like that is the compensation piece, but also the burnout factor. I mean, like, there's so many people coming in that it's like you have to do a lot in order to be able to not burn yourself out. And then you have to, like, it's been my experience, you have to tell the people that you're working for, like, hey, I'm burning out. I don't want to burn out. Help me out. And if they're not willing to help you, you know, and like slow down the flow, or, you know, bring other people on, then like all the money in the world isn't going to do anything.
Well, and it becomes disheartening for the people that are working, like the techs that are working and the counselors that are working with patients, if they know that this was a guy that was, you know, on their unit 2 weeks ago, you know, and they see him back and they're going like, this guy's just going to be back in 2 weeks, you know, why should I, you know, treat him as a human? I mean, it's like, that's unfortunately, I think that happens sometimes. So but the point I want to make is that these folks, they get it. You know, at some point they get it. We just recently started referring patients to these out-of-state providers. And one of the best things about working in this area is that I was working with a woman that had experienced an unspeakable trauma, you know, and most of these patients have had, you know, just ridiculous amounts of childhood trauma, you know, and this woman in particular. But we were able to get her into a program that had specific treatment for trauma for women, right? And she was able to go. She came back. She called me on a Saturday night, and she said, I just want to let you know, Mr. Coffey, thank you. I just want to let you know I'm back. I'm doing good. And, you know, and it's just a blessing that, you know, that I was able to go to this place and, you know, this is what I'm doing. And I just like, you know, all of the people that I see over and over and over again, it doesn't matter. I mean, this woman, so people get it, you know, and she had been to treatment a number of times. So recovery works. That's the message, right? And it doesn't matter, you know, how long it takes for, you know, I wonder sometimes, Lord knows I tried to quit a lot of times, you know, I only had to go to treatment once, but so far, but I certainly tried to quit a lot of times, and I'm not going to question, you know, why I got it when I got it, but I did, and I'm here now. And but the message I want the people that I work with to know is that recovery is possible, you know, and you just got to take advantage of it.
So what I hear you saying is,
and you get the chance, hopefully, that, you know, they have that moment of clarity where they're able to see it, you know, Lord knows how it works, but.
Right on. So what I hear you saying is that person-centered language reduces moral injury, which reduces burnout for the recovery care team.
That, I think that's, you know, that's the line that, you know, you connected the dots, right? You know, a lot of people, I don't know what the figure is, like 1 in 9 seek care, you know, and a lot of people that we see, I think a lot of them don't believe that they deserve it, you know, that they don't deserve to find recovery, and they do, you know, and so it's and when we have an interaction with somebody that's coming in that, you know, that's in the system, it needs to be a positive interaction. It doesn't need, we don't want to perpetuate the stigma. You know, they're already feeling less than, you know, and the message that I always, you're not your illness, right? You are, you know, who you are. You're, you know, I'm Bobby Coffey. I'm not an alcoholic, you know. I'm a person in long-term recovery. I'm not my disease, you know. For a long time I thought I was.
Right on. So let me ask you this. Oh, that was me in your thing. So I'm with you, right? Like, I didn't get to go to treatment. I say I didn't get to go to treatment because when I got sober, like, there was no, I mean, treatment was not available for someone like me. I mean, like, I would forget where I lived and sleep in the back of my truck for weeks. You know, it wasn't because I didn't have a job, you know, so like treatment was not available, you know, and now treatment is available, right? And I think that how we treat people, right? And you've alluded to this, right? So when I want to say this because we're going to put this in the notes, right? Is when we talk about recovery care team, what we're talking about is the recovery care team model from incentivized recovery, right? That addiction recovery medical home model. So when you are working with peers using the addiction recovery medical home recovery care team model, like, what are you doing? Like, how are the peers integrating into all of this, like with the counselors and with the medical staff and, you know, with the community itself? Like, how are you guys working as a team to connect people? Because I've heard you say we get some people government issued licenses, and some people, like, I'm assuming like you got to get some people insurances and like connected to other services. How do you do that?
Yeah. Well, I think I think one of the things it's important to recognize is that, and I think at PIW they do recognize this, is that the peer counselors are a valued member of that team. There are things that we know that as a peer we're able to communicate. We speak the language of the client that sometimes other members of the team can't. So there are things that we can do um, to further their path to recovery that maybe somebody else on the team can't do. So
They're credible.
yeah, exactly. And so, and I don't hesitate to share, you know, that I have the lived experience that they have. You know, this is, and I think that it's really, really valuable. And I think if you know, when they're talking to a social worker that may not have that, they don't have the ability to do that. And I think a lot of times that client will sort of sit up and take notice that they know that, okay, you know where I've been, you know why I'm here, because you've lived it, right? So there are things that we can't do, you know. I'll be honest, we have not been successful in, you know, in getting, you know, because when I get involved, you know, with a patient, it's usually, you know, because most patients are there for 5 to 7 days of detox. It would be great to see them there longer, but they're not. And the first 3 days are usually a wash because, you know, we know that, you know, somebody coming in to detox, the first few days, they're just getting stabilized and they're, you know, they're going through withdrawal symptoms and they're not comfortable. And, you know, so we don't even get to talk to them until the 3rd day. And it may take, you know, the 4th or 5th day to find a good place. And then we find out that they don't have a license. We can't get a lot of that stuff done, but we can find them a suitable place to go and connect them with a peer so that, you know, that they can do that and the peer can develop a recovery plan for them, you know, like what, and that's where your recovery capital comes in. Like, what are the areas that we need to sort of build on? Do we need your, you know, is it your education? Is your health? You know, is it legal issues? You know, how do we connect you with those kind of services? And I think a lot of patients have just been flying blind. You know, they come in to a detox, they get stabilized, and we're discharging them back to the environment where that it may not be the healthiest environment, you know. And so it's so important, you know, and I don't even think you have to have a huge change to make a really big difference in somebody's life. You know, if you can get somebody, if we can increase that percentage from 25 to 30% of people that go to the next level of care, whether it's IOP, intensive outpatient, or residential, that makes a huge difference. Because if you think about it, like I said, 300 to 400 admissions and discharges a month. That's a big difference, right?
That's huge.
But it's going to take a lot more bodies, you know, and that's why the work that you're doing with training peer support people is super, super important.
Thank you for that. Yeah, I agree with that.
And the other thing that we're trying to do with Recovery DC is to create a you know, like everybody has a professional association, right? You know, doctors have their you know, the AMA, you know, nurses have their associations, you know, got the association of, you know, you got ASAM, and, you know, everybody's got their professional association. We wanted to create an organization for peers that provides them with resources, whether it's, you know, places to get additional education, you know, certifications, or places to accumulate their hours, or, you know, do internships or even jobs. You know, we want to provide that additional training. I mean, if you think about it, people that, you know, peers, a lot of times peers are people that can really early recovery themselves and need that workforce development, you know, component as well. So that's what we're trying to do there, is and provide a place for them to come and get that help that they need.
So
Somebody that actually wants to do that, like, you know, wants to be of help, it's nice to know where you can go to access that kind of credentials, information, how-tos, you know, because I think that's I would say that's kind of a general census. I mean, I think there's a lot of people that want to be involved and don't know how to be involved.
Right. And the thing that there was a really good study, I think it was out of maybe Boston General, that did a study on working with people and trying to increase the number of people that were going from stabilization or detox to the next level of care. And so they did a control group with just doing it the way they were doing it. And then they did another group where they provided additional training for peers in the disease of addiction, and enhanced motivational interviewing techniques.
Right.
And they that group that saw a pretty significant increase in the number of clients that were able to go to that next level of care because of the enhanced training that those peers got. Like I said, in the disease of addiction and motivational interviewing. And I think that's something that we need to be doing as well. And I don't know if y'all know the work of Tom Carl at R1.
Love Tom Carl. He's those stages of change cards.
Oh yeah, Joanna loves that guy.
Tom is great, and he's doing incredible work, and that his R1 learning tools are being used all over the country now, and he's providing that workforce development component to the peers that we're working with. So shout out to R1 Learning.
Yeah, right. Well, because I mean, if I think about it, like when I sat in treatment, the people that I gravitated to initially, especially, were the techs, people that had no formal education in it, right? Like I just knew that they came from the same trash can I came from, right? Like that's how it felt in the moment. Like that, that's when you're at your worst, like you feel the worst. And I knew by sitting across from somebody, having a conversation about shared experience, like I connected with them in a completely different way than I connected with my clinician. Even if my clinician had been in recovery, there are those boundaries that they have that they have to have in order to keep the relationship between clinician and patient or client safe.
Right.
And whereas like the peer isn't held to, there are boundaries, but it's not quite the same. And I love that. Like that's, I don't know, there's something magical about it. There really is.
Right. I never thought about that though, that you may have a clinician that does have personal experience, but rarely or their code prevents them from sharing that with you, whereas we're not restricted by that, and like I always say, we're uniquely qualified to make that to work with those patients. And yeah, it's a really good point.
Yeah, I like that point too. Well, and that's the kicker, right? Is that each one of us on the recovery care team like has something that we do really, really well, and together we can really help people.
Right, and the thing I've been spending a lot of time, sort of during COVID, this is the thing that I've been working on, is this care coordination piece. Is like, like when do we introduce that client to a peer specialist, and then so like we've been doing it via Zoom, right, while they're still in detox, and getting them to electronically sign consents, and then ideally they're going to residential care, and that peer is still connected to them while they're there, and when they get out, the peer is waiting for them, and then they continue to have that interaction, and they're doing their care plan, the recovery plan, and that peer's got their relationship with them, and is connecting, making sure they're connected with 12 steps, making sure they have a sponsor, making sure they're doing all of those things, and it takes that, it's like, it does take a village, and it takes a recovery village, right? And in the rooms we talk about, we build, a fellowship will grow up around us, right? And, that's what we're trying to do here, is to build that fellowship around these folks, and so it's great work. It's like, I never dreamed that this is what I would be doing, but I'm so happy to be here and to be working in the area that I'm working in, and it's a real challenge, and it's something I'm learning every day, and I'm working really with incredible people that are working under challenging circumstances, and trying to do the best thing for the folks that we work with.
That's incredible. Yeah, you've come a long way from not wanting to talk about your recovery to like now the work that you're doing.
Right.
And to think like, dude, it started because you heard someone else talk about their experience on the floor of Congress, and then you also like participated in this person-centered language study.
Right. And it's like I got to, Ramstad was one of the ones that spoke, and I've seen Congressman Kennedy as well, but Jim Ramstad passed away just a month or so ago, and they had a virtual memorial service for him, and it was so moving, to see the lives that he touched by doing that, and it's, you really can, ordinary people can do extraordinary things, right? And
every day, every single day.
Yeah. And so
I got chills.
Yeah, man. It's so true though. Like you have probably touched so many people's lives, and you'll never know.
Right. Well, a lot of people have touched mine, and I spoke the other day at a meeting for my anniversary, and I told the story about that. About 10 years ago, I picked up the phone and I called a doctor that was my doctor when I was going through treatment, and I called him to thank him because very few doctors understand their limitations. This doctor did, right? And I remember him telling me, he said, Bobby, he said, I can manage your medication and your depression and all of that stuff while you're here. He said, but your life is not going to get any better unless you develop a community of recovering people as soon as you get out of here, and I did that, and I called him up and I told him, I said, Dr. Hillsman, I said, I just want to let you know, that I'm working in the field now, and I've got 20 years of sobriety, and that was 10 years ago, right? And I want to thank you for that message, because it's the same message I give people all the time, that leave our program. It's like, you did great here in the 16 weeks you were with us, but your life will exponentially get better if you develop a community of other recovering people, because we can't do this.
Absolutely.
I love it.
Yeah, I live and die by that thought, quite frankly. Yeah. I mean, for me, it's as simple as if addiction is to isolation, then recovery is to community for me.
Right.
Yeah. And the second I'm like, I'm all right. No, you know what I mean? Like, I don't really need to call anybody or talk to anybody. And COVID like played some mind games with me on that, honestly. And, luckily I had been immersed enough in recovery and had some really amazing people around me being examples of what strong, healthy recovery looked like, that I was like, ooh.
Yeah.
It's so dangerous. What are you talking about, girl?
The work that y'all are doing is super, super important, and I'm proud to be working alongside y'all, and I think you're going to do really great stuff with this podcast, and I can't wait to watch you.
Thank you so much. I really appreciate all the time that you spent with us, and I mean, the knowledge that you've dropped on us, I've written like an entire note here.
I know, I did it too. I did too. Bobby, you're such a cool dude, man. When Joanna was like, Bobby's gonna do our first podcast, I was like, no way.
I was just really, I got that email and I was going, oh my God, of course. That's great.
If no one ever watches it, just to have like kicked up with it for like a half, like just, you know, talking to Bobby, I was like, oh, I'm so down. Like
What are you
that's,
talking about? We're going to share it everywhere.
yeah, right on.
Yeah. Wait till you see our logo. Woo!
Yeah, right on, right on. Because I think it all comes from like, you know, just a genuine desire to try to help another alcoholic and addict, right? That's really it at the end of the day. At least it is for me, and I know it is for Joanna and Bobby. It sounds like that's, you know, what, there's none of us that are in this for the money. Let's
No, that's
really.
And let's not forget also the families, you know, I mean, it's like,
Yes.
you know, this is a family disease, and I work with a lot of families that are just like at their wits' end. And, you know, if we can give them a little bit of hope that recovery is possible for their loved one, I mean, that's a big step too. And I always, you know, say, listen, take care of yourself, you know.
Yeah.
You know, we want to help your child or help your husband or your son, but, you know, take care of yourself as well.
Yeah, wise words for sure. Well, one of my favorite clinicians from Colmac, her name is Mary Walsh. She runs the family group there, and she always says it's easier to be us than it is to love us.
Exactly.
And I'm like,
Oh yeah, can you imagine?
You're probably right. You're probably right. I can't. I don't want to imagine. No.
But it says there's a line in the big book of Alcoholics Anonymous says that an alcoholic in his cup is an unlovely creature.
Yeah. There's some
1935, talking about language, that's 1935 language.
Yeah. There's a lot of great one-liners
today.
Oh man, this has been terrific. I really appreciate you. Well, I guess we'll just wrap it up. I don't have a great tagline for wrapping it up, but maybe we can say it like this, right? Like recovery capital is about the internal and the external stuff that you need to get into, maintain, sustain, and recovery, but really to go from like barely surviving to thriving and enjoying your life. And you have just given us an entire, I think we went over a little bit of an hour, but you've given us this entire blueprint to see like no matter where you are, no matter where you start, like you can not only impact entire groups of people. I mean, I think about all the people that you've impacted, and you've impacted us, but you can be really chill about it too. So thank you for having some fun with us, dropping some knowledge on us, and showing us like how to be chill.
Thank you both so much. I really enjoyed it, and I'm looking forward to watching you guys continue the work that you're doing.
We appreciate it, Bobby. Thank you, bud. Appreciate it.
All right.
See ya.
Take care.